Hello and welcome to the Fix Your Fatigue podcast. Whether you can't get out of bed in the morning, your energy crashes throughout the day, or you're a biohacker looking to optimize your energy, productivity, and focus, this podcast is for you. I am Dr. Evan Hirsch, and I will be your host on your journey to resolving fatigue and optimizing your energy. And we'll be interviewing some of the top leaders in the world on fatigue resolution. Welcome. Hey everybody, welcome to another episode of the Fix Your Fatigue podcast. I'm so excited that you're here with me today because I'm going to be speaking with my friend Dr. Amie all about thyroid. So let's learn about Dr. Amie and who she is. So Dr. Amie Hornaman is a leading certified functional medicine expert on a mission to optimize thyroid patients around the world and give them their lives back using scientific elements of nutrition and functional medicine. After her own experience of insufferable symptoms, misdiagnoses, and improper treatment, Amie set out to help others who she knew were also going through the same set of frustrations and who were on the same medical roller coaster. She consults people around the world via telehealth virtual appointments, beginning with an in-depth 90-minute consultation addressing everything from lab values to nutrition to lifestyle. She specializes in clinically investigating underlying factors of chronic disease and customizing health programs for thyroid issues, autoimmune conditions, hormonal dysfunctions, digestive disorders, and brain problems. With a focus on optimizing thyroid function and thus optimizing her patients, Amie looks at each person as a unique individual and not just a lab value. So important. She examines all factors that tie into thyroid dysfunction and thyroid symptoms and treats the person from top to bottom to give them their lives back. Dr. Amie, thanks so much for being on the show today.
You're welcome, and thank you for having me. I'm excited to be here.
So let's start off by talking about your story of thyroid and no doubt fatigue. Please share with us.
Yeah, for sure. So I think we all come into this space with a pain to purpose story where we went through something and then we learned from it and then want to pass it on to others so that they don't suffer like we did. So my story goes back 20, 25 years. I was competing in fitness and figure competitions and doing fitness modeling. So for each event or photo shoot, I would diet down because I don't come from a naturally thin, lean family. We have diabetes in my family, the whole deal. And I would really have to work my butt off to get down to that size to stand on a stage in a bikini or to get in front of the camera. And I had done it multiple times. I knew how to do it. I knew what worked for my body. So this was like time number, 15. And all of a sudden I'm gaining weight instead of losing. So here I am on this really strict diet. I'm going to the gym twice a day. And I'm like, something's not right. And then the fatigue comes on. I can't even get through a workout. I can't, much less 2 workouts a day. I can't get through one. I'm not working well. My brain fog is horrendous. I'm losing hair. So I go on my doctor search like all of us do. And we think I'm just going to go and get tested and they're going to tell me what's wrong with me. So I go to 6 different doctors. They all told me to eat less and exercise more. Mind you, I'm eating broccoli and asparagus and fish and chicken. Like, I can't eat less and I can't exercise more. And what is wrong with me? Can someone please just give me an answer? So the 7th doctor finally diagnosed me with hypothyroidism, felt my throat, told me to swallow. So you have goiters and you have hypo. So I'm like, yes, I get a pill that's going to fix this. And, I wasn't in the functional medicine space at the time. So I'm thinking this is the answer. So I'm going to feel better. 5 months later, no change in fatigue, no change in my weight, not 1 pound. So now I go back to my doctor. I do some research on Dr. Google, right? Here's some proper treatments. Here's what I should be doing. And she goes, I don't do that. I said, I'm going to find someone who does. So that led me to a functional medicine practitioner, gave me all the answers, the proper testing, the proper treatment, nutritional changes, lifestyle changes, testing everything else, all those other factors that come into play with hypothyroidism, and literally gave me my life back. He became my mentor and now really led me down this career path because I wanted to do what he did. I wanted to fix people.
Brilliant. And that's such a common story. It's shocking to me. the people that I see with fatigue, who's pretty much everybody, I would say 9 times out of 10, they have a thyroid disorder, and 9.5 times out of 10, it's not optimized. It's not
Right.
being treated appropriately. So why do you think that's the case?
Oh gosh, I wish I knew, because I go into this so much when I talk to patients, and they ask me that too. Why has no one ever told me this before when I tell them what I'm seeing? And I think it comes back to what they learn in med school: test the TSH, treat with T4, and that's it. And it was interesting. I had heard an interview with Dr. Brownstein, and he stated that in med school, his one professor, and we need more professors like this in med school, one professor told them that 50% of what they learn will be outdated, null and void in 5 years.
Right.
50% of what they learned in med school. And I think that's the problem, is that doctors get into their practice and they don't go deeper. They don't review what they learned in med school. I mean, that's my only guess. So they stick with what they were taught, and that's it. And really, that's where we come in, right? Going deeper, looking for the root cause, testing more, test, don't guess, realizing that there's more treatment options available for people out there than just T4. Here's some Levo.
Right.
Go have a great day. So I think there's more options that conventional docs, if they don't think outside the box, or if they haven't gone through a problem of their own or with a family member, then they're just stuck in their conventional medicine box, and that's it.
Yeah, I would definitely agree with that. When I went through medical school, they told us the same thing. And actually the suffix on that was, 50% of everything we teach you now is wrong and outdated in 5-10 years. And we don't know which 50% that is.
That is right.
Right. And so that is definitely the challenge. And it seems like for a lot of practitioners, a lot of conventional docs, the lack of curiosity, I think, comes from, hey, this was good enough for my mentor, and my mentor taught me, and I love my mentor, or I loved my residency, or whatever it was. And so this is kind of what I'm going to continue on. Plus, also, if you're looking in conventional journals, that's what you're going to, it's just going to reinforce. You have to kind of get out of that paradigm. And a lot of people, they're never some of them are never even exposed to integrative, functional, more natural medicine sort of stuff. So I definitely agree with what you're saying. So you talked about TSH and you talked about T4. Let's talk about laboratory tests. So what's being used conventionally, and then what do you like to use?
Right. So if you go into your family doc, conventional doc, even your endocrinologist, if you get sent to a specialist, they will test TSH and maybe free T4 if you're lucky, but that doesn't leave you very lucky, because you're missing out on free T3, reverse T3, and the thyroid antibodies, TPO and TGA antibodies. Now there's other tests too. There's total T4, there's total T3, there's T3 uptake. Those are kind of bonus tests, but the core that I like to see: TSH, free T3, free T4, reverse T3, and the 2 thyroid antibodies. Sometimes people will only come with one tested. They'll only come with TPO. It's like docs forget that there's that second one. There's that TGA antibody. So we have to test that too, just to check for Hashimoto's. And that gives us the full picture of your thyroid health.
Okay, that's great. And so in terms of talking about those in the context of physiology, like what are they actually measuring in the different those different steps?
Right. So here's the fail in only testing TSH. TSH is a pituitary hormone. It's released by our pituitary. It's thyroid stimulating hormone. So I like to give analogies when I teach my patients. So you might hear me tell like analogies and stories. But so TSH, I compare it to like the pituitary is feeling like, hey, is there enough thyroid hormone in the body? Is there enough here? Oh man, there's not enough. Okay, hey, thyroid hormone, can you wake up a little bit? So it stimulates the thyroid gland to produce more of T4 and T3, the 2 thyroid hormones. So it's kind of poking it. And that's why I say TSH is one of the only lab values you'll see in blood work where high means low. The higher it goes, the more hypo and low your thyroid is, the more low you are functioning. Everything slows down. So that's good to take a look at. And listen, if you're coming back and TSH is sky high and the pituitary is screaming at the thyroid, guess what? You have a thyroid problem. And that's probably when you'll actually be paid attention to by your doctor, is if you are flagged high with TSH. Now, the downside of testing TSH is number one, the range. So conventional medicine has this huge range, right? We use the target on the side of a barn analogy. You have a barn, and if I give you a ball and I tell you to hit the side of the barn, you're probably going to hit it from 50 feet away, right? You're probably going to hit it. But if I put a bullseye on the side of the barn, that's the functional medicine optimal range. That's where we see you being your best. That's where you will feel your best and be optimal. Not side of the barn range, but target on the side of the barn range. So TSH is been debated for years. It's narrowed down. It's narrowed down now on most labs to 4.5. In functional medicine, we still say below a 2 is optimal. Anything above a 2, we start to go, yeah, if you got symptoms, that might be hypo. So then let's go further. Now let's look at your free T3. Make sure that's optimal. That's the most important one. T3 is the active thyroid hormone. Without it, your cells are not going to thrive. You're not going to have a metabolism. You're not going to have energy. You're not going to grow your hair. Not going to be in a good mood. You're going to be constipated. So really not testing free T3 is like a crime. We need to see what your active thyroid hormone status is. And if that's low, that's a problem. Again, low by functional standards is below 3.5. I like a 3.5 or above. Some people even do better in the upper range in like 4 or 5. And then we go to reverse T3. So if we're thinking about free T3 as the gas, that's what runs the show. That's what gives you energy, gives you metabolism. Then we have to look at the brakes, and reverse T3 is the brakes. If that's high, and again, above a 12, so you might not even be flagged. You could be riding around with a reverse T3 of an 18, a 20, 22, and no one will say a thing. That's even if you can get it tested. No one will say a thing because it's not flagged. It's not red. You don't have the H next to it. They're not stopping and looking. But in functional medicine, if you're above a 12, we say, hey, you might have a conversion problem here. Too much of your T4 is converting to the brakes. You got the brakes on. You have no gas. You can't run this car. Your brakes are on all the time. You're trying to push this car down the road and the brakes are on. So that's the reverse T3, why we look at that. Free T4 is important. We glance at it. I look at it. Each situation is different depending on the medication a person's on and how much and where that goes and whether they're converting or not converting or T3 only. And then we have to look at the antibodies. Those antibodies, again, a lab could have you normal range is less than 20. But guess what, folks? If you're coming in with a 15 with your TPO antibodies, you have soldiers that are attacking your thyroid. You have autoimmune. It's just not flagged yet on your labs, but it eventually will be. Why not catch it before it gets flagged and say, hey, there's the presence of autoimmune here. There's the presence of Hashimoto's. Let's stop your body from actually attacking your own thyroid. So that's what each of those labs mean. And that's why it's so vitally important to look at all of them to get that full picture.
Yeah, that's great. And so then what do you like to see for free T4?
So free T4 is funny. I say 1.5 or above, but right. So if you're a T3 only candidate like myself, I do not convert. You give me T4 medication, I get worse. I go hypo. My reverse T3 goes up, I go hypo. So my free T3 or my free T4 rather is low. It's flagged low, but that's okay because of the scenario, because of my individual situation, the medication I'm on. My free T3 is good. My reverse is down. My TSH is below a 2. In fact, it's kind of suppressed. So, and since you're more than a lab value, we go, how do you feel? So I can answer mine. I feel great. I'm optimized. I'm fine. My energy is great now. I lost the weight. I am optimized. So I don't really care about the free T4. Now, someone else comes to me and let's say they are not diagnosed yet, or they're on T4 only, or they're just not feeling right. Then we do look at that free T4. We want to get that whole picture and see like, okay, listen, if your free T4 is a 0.8 and your free T3 is coming in at 2.5, but you're normal, everybody's telling you your labs are normal, they're fine, they're within normal limits, that's still a red flag for me. Now you have too low thyroid hormones. So we have to look deeper. What is causing that? Is it the destruction of your thyroid from Hashimoto's? Is it an underlying infection that's just tanking your thyroid? Are you taking a medication that's tanking your thyroid? So many different factors that are dropping both of the thyroid hormones from being produced in proper amounts.
Yeah, a lot of really great things you've just said there. I think what's, one of the most important ones is to pay attention to the symptoms. How do you feel?
Yep.
Right?
How do you feel?
Because as you mentioned, sometimes the labs they don't correlate with how somebody feels. So we always want to use them as data, but we want to go with the subjective experience at all times. That really is the most important thing. So thank you for bringing that up. The other thing, or the question that I have for you, my ranges are just a little bit, I think, tighter than yours. I
Okay.
like, which is great. We can have a conversation about it. I
Yeah.
think, TSH, I like it to be between 0.5 and 1.5. The free T3, I like it to be above 3.0. The free T4, I like it to be above 1.2.
Mm-hmm.
So I guess my question to you around the reverse T3 is that I understand that, well, I guess the question is, why does reverse T3 get elevated? Let's start there.
Oh, really good one. Okay. So many causes can elevate reverse T3. So let's say you land in the ICU, and this is an answer to your previous question of why doctors don't test. You'll often hear, if you ask for reverse T3, we only test that in the emergency room or in the hospital. You don't need that tested. Well, you do. Yes, you do need that tested outside of the ER or the ICU. Your body will naturally elevate that. It's a survival mechanism. So your body's going to elevate your reverse T3 to slow down your metabolism if it needs you to survive. And that is a natural occurrence that we see. But what if you're not in an emergency situation? Then we have to say, why is your reverse T3 going up, right? Is it that you are on too much T4 and you're not converting properly? Your doctor just keeps pumping up your T4 dose, and now you're taking 180, 200 micrograms of T4, but you're converting all of that to reverse T3. That's a possibility. You could be anemic. You could have high insulin. You could have low iodine, low selenium, low magnesium, all those conversion factors that are so important. You could have just generalized inflammation, Epstein-Barr virus, Lyme disease, all the things that you talk about, Evan. It could be those co-infections running underneath the surface that's pushing that reverse T3 up and putting your brakes on.
Gotcha. So then that reverse T3 is giving you a warning sign that, hey, there's one of these things going on that's causing this thyroid dysfunction.
Definitely. And causing that conversion issue. So that's where we can come in and help a person who is, I like to say, like stuck in the synthroid box, because I see so many thyroid patients like that are just on T4 and their doctor won't change it, and they don't like Armour and they don't want to use T3. Well, then let's help that conversion. Then let's address all of those factors that could be pushing that reverse T3 up, so that we can get that down, take the brake off, so your gas can start and that conversion can happen more fluidly.
How did I get in this synthroid box, right?
I know. It's what we've been taught in med school, right?
Yeah, that's really good. I really like that analogy. So then in terms of the antibodies, so we know that 90% or so of all low thyroid is autoimmune. Would you agree with that statement?
Yes, 100%. Yep.
And so then checking the antibody, if we know that, then what sort of additional data is checking the antibodies going to give you?
So, antibodies can fluctuate. I try to not have my patients hyper focus on the antibodies, because some do. They'll be like, well, I was, 700 last time we tested and now I'm 1200. Okay, well, maybe you were under stress. Maybe did you eat some gluten last week? Because that can push your antibodies up. So I don't want to base a person's success on the presence or non-presence of antibodies. And a lot of people talk about pushing Hashimoto's into remission. Yeah, we can kind of do that, but you could be in remission. You could be feeling good. Like, you could test me now. If my antibodies are 5,000, you know what? I don't care, because I feel good. It goes back to how you feel. I am fine. I am optimized. And maybe not 5,000, but you know what I mean? If they came back at like 900, I wouldn't panic and think that I have to do this major overhaul, because I know they're fluctuating. Maybe it's because I'm working too much. Maybe I didn't get enough sleep. Maybe I did eat that bun with my burger that I probably shouldn't have. So it still has to tie back to how you feel. But the I guess data that those antibodies provide us is someone in the state of Hashimoto? Are they in an autoimmune flare? And does that correlate to why they feel like absolute garbage? And then if they're not doing what they're supposed to be doing, if we see those antibodies continuing to climb, that's when we do have to look for, okay, which we should probably look for earlier. Is there the presence of an underlying infection? Is something else driving those antibodies up? Are you binging on gluten or something? Because this isn't right. And then we look a little bit deeper into behavior of the patient.
That makes a lot of sense because, yeah, you could be feeling great and still have elevated antibodies, which means there's still something that's triggering that. And there's still some work that needs to be done to make sure that you don't get this progression of just the thyroid being destroyed over time, right?
Right. Yep, exactly.
Because that's kind of what's happening, right? What's that natural progression of Hashimoto's if it's not treated?
Yeah, I mean, there's 5 stages, 6 stages, 5 stages, 5, I think. So you start with, it varies from what you see online, but you start with that natural inclination, the genetic predisposition to have autoimmune. So look back in your family. I just met with a patient today. She's never been diagnosed with Hashimoto's, but her mom has Graves. Her gram has type 1 diabetes. And somewhere in the lineage, there's like MS. I'm like, okay, then it's probably Hashi. Because if we deduce that 90 to 95% of hypothyroidism is Hashimoto's, and she was diagnosed at like the age of 15. I'm like, I really don't think that you did anything to destroy your thyroid. So where it's just hypothyroidism, like we see with extreme dieting, over exercising, certain medications, radiation, chemotherapy, none of that's going to occur before the age of 15. If you're getting it at 15, it's Hashimoto's. So you have that genetic predisposition stage. Then you move into where you might have antibodies, but your thyroid labs still are, I'll use the term normal with air quotes, normal. And then stage 3, we start to see those numbers change. So now your TSH goes up, free T3 and free T4 go down. We actually start to, now you could have symptoms in stage 1 and 2, but by 3, you might actually be diagnosed. And by the time you reach stages 4 and 5, now you're progressing into those other autoimmune conditions, because where we see one, we see more than one. So you're right, Evan. I mean, the goal is to stop it in its early stages. So your soldiers that are part of your autoimmune system, like those confused soldiers, like I say, aren't going out and beating up your thyroid, because once they're done, they'll find something else. Maybe they'll choose your joints and you get RA. Maybe they'll choose your small intestine if they haven't already, and you got celiac. So we see this progression of autoimmune conditions.
Yeah, I'm glad you mentioned that. That's such an important point. Like when you have autoimmunity, it's never just to one organ. If you're having joint pain as well, then it's very possible that the autoimmunity, the immune system is attacking that in addition to the thyroid. So then we've talked about how thyroid or low thyroid is kind of this 2-part where you've got low thyroid hormone, and then you also have the autoimmunity. So which one do you go after first?
Both and. Both and. So we want to start, since the thyroid is the master gland, and we want to give you a quick win, right? So we want to make sure that you're on the right medication, that you're doing everything to support thyroid function, all your micronutrients, all that. It's great. And then at the same time, we want to make sure that you're not running around with high blood sugar and high insulin, because that's just going to negate all of our progress. Anything that we try to do medically will be negated if you're pumping up your blood sugar and your insulin, which is going to increase inflammation, which is going to make the thyroid not work well anyways. Whether you're in hypo or Hashi state, you're done if you're walking around with inflammation. So lower the insulin, lower the blood sugar, address that issue, test for it, look for it, treat for it naturally, berberine, love that. And then move down the road to the dietary and lifestyle changes. Because if someone's stressed out all the time, they're pumping out cortisol. That high cortisol will raise blood sugar and insulin. That will create inflammation. And cortisol in and of itself being high will interfere with T4 to T3 conversion. So as we're trying to help your thyroid over here, you're running around all stressed out and pumping out cortisol left and right. Again, it's not going to work. So it's kind of the both and. We have to address everything at the same time.
Yeah, that makes a lot of sense. So one of the things that I do first in my programs, for some of the similar reasons that you mentioned about getting a quick win and everything works better when the thyroid is optimized, is I optimize the big three, like the adrenals, the mitochondria, and the thyroid. Would you speak quickly to that relationship, what you've seen that looks like?
Yeah. So adrenals, we can see high or low. And with adrenals, people, my patients usually come in and they just say, my adrenals are blown out. Like they're shot or adrenal fatigue. And that might be the case, but we don't know until we test. And we have to test those points of cortisol because we are supposed to have higher cortisol in the morning to wake us up. And then it's supposed to go down throughout the day and then be lower in the evening to just make us chill out and relax. Now, I'm sure I've seen everything from flatlined low, where people literally are not even putting out enough cortisol to survive. We need cortisol. We don't want to suppress our cortisol. Without enough cortisol, we're dead. So we need some, we just need it in the right amounts and the right pattern. So sometimes people will have flatline low. Sometimes people will be flatlined high, pumping the cortisol all day. Your adrenals are literally overworked. And that's going to interfere with the thyroid as well and create a ton of inflammation. So in the flatline low, you're going to be tired. You're not even going to want to get out of bed. You're going to be shot. And then you have the thyroid over here not working properly. You mentioned mitochondria, all functions go down. Mitochondria goes down. ATP production goes down in the cell. You have no energy in that state whatsoever. You're done. Now you say, okay, well, what about the high cortisol over here? Yeah, but that can only last for so long. Our adrenals can only overpump cortisol for so long. You're eventually going to crash. So you might crash down the flat line low. Now, again, tie back to thyroid, mitochondria, everything, boom, down. No energy production whatsoever. Or worst case scenario that, again, I just saw today, a reverse curve. So now you're low in the morning and you go high at night. So now you can't get out of bed in the morning. Nothing's working. No ATP production. Thyroid's low. Cortisol's low, but then you get adrenalized at night right before bed. And these are the people that get that second wind and they get the rush and they get the tight chest and they feel like they're having a panic attack at 10 o'clock at night when they lay down to go to sleep. So they're in that reverse curve. Yeah, it's all tied together. It's amazing when you look at that whole picture and everything is tied together. But at the cell level, listen, you have to have that decrease of if the cell's inflamed, nothing's working right. Yeah, I mean, you're alive. You're alive. You might be dragging yourself through the day, but the whole Krebs cycle, ATP production, it just goes down. Think thyroid low, low, low. Everything is low. Your metabolism is low. Your energy is low. Everything's low at the cell level. Your bowels are low. That's why you're constipated. You're losing hair because your hair growth cycle has now slowed down. Everything is low.
Mm-hmm. Yeah, that's brilliant. It's so important to remember that you can't just fix it with Synthroid.
Right.
Yeah.
Right.
Yeah. So then in terms of thyroid's relationship with fatigue, like how does the thyroid make energy? You kind of talked a little bit about it, I guess, but how does it make energy that ends up, or how does it, when it's not working, how does it cause fatigue?
Cause fatigue. So we talked in the beginning about T3 being that active thyroid hormone. So if we go back to the cell, every single cell in your body, cells in your brain, cells on your heart, every single cell in your body has a receptor site on it for T3, the active thyroid hormone. So that makes it interesting when we think we're giving people T4 and T4 is totally inactive. It's the storage. It's like the gas that's at the gas station in the pump. Like you gotta, it's not running your car yet. So it's just in storage. We don't have receptor sites on our cells for T4, only T3. So we have to have that proper conversion of T4 to T3. And listen, our natural thyroid in a non-sick, in a euthyroid state, you're making roughly about 80 to 90% T4 and around 10 to 20% of T3 naturally, because the body knows that most of the time people will convert T4 to T3. But even the body is so smart to say, but we're still going to give a little bit of T3 to this person, just even to 10, 20%, just to keep them going, to skip that middleman, skip the conversion factor, because a lot can go wrong, and just give some of the cells a little bit of what it wants, a little bit of that T3. In a non-sick person, that's enough. in a sick person, we see a total decrease in the production of T4 and T3. We see that T4 to T3 conversion issue. Now all of your cells are starving for T3. They're not getting it. And that's why we have the brain fog. I mean, people forget that there's T3 receptor sites on brain cells. And they wonder, I mean, I have people, I don't know about you, Evan, I'm sure you do, but I have people say, maybe I'm in like early stage dementia. I don't know, it's just your thyroid. I mean, your brain's not functioning. Nothing is functioning unless you have that proper amount of T3. And then we can go deeper and say these poor people that have total thyroidectomies, we take their thyroid out that once produced T4 and T3, and we give them T4. How does that make sense? We're not even replicating what the thyroid did naturally when it was in their body functioning. So we rip it out and only give them one hormone. Right. I mean, yeah, they're going to feel like garbage, of course.
So then what do you like to use to convert T4 to T3?
So definitely magnesium. We're all low in mag. We're all low in mag. I love mag. Selenium in the proper amounts. I see too many people reading like thyroid blogs and in groups, and they pump out, 200 micrograms of selenium every day, and then their selenium's too high. That can be a problem with conversion. I want to make sure that their ferritin levels are proper. So we test, don't guess on that. We want to make sure you're not anemic. We definitely want to check that ferritin, make sure that that's in an optimal range. So we can use things like, ferrotyl iron, vitamin C, all that to raise that. Zinc levels are vital for T4 to T3 conversion, also vital for your hair. So if you're losing hair, you're going to want really good zinc levels, and you're going to want that for the T4 to T3 conversion as well. Iodine, I am in the middle right now, but I am intrigued, let me say. I do believe we need iodine. I do believe we need some. I think it is the Goldilocks kind of element that we have to fall right in the middle, because the truth is our thyroid needs it. The truth is it binds to bromide and chlorine and excretes it out of the body. I don't know. I want to talk to Brownstein about going the high dose iodine route. I'm not sure what your take is on that yet, but I am super intrigued with it. But I do believe we need some in order for that proper conversion to take place. And then again, supporting the immune system with vitamin D, looking for underlying infections and treating those, especially if you're an active EBV, that's going to be a problem. You're just a ball of inflammation. That's an issue. And then insulin. Insulin is a huge one. I see so much insulin resistance with hypothyroidism. Probably, I would say 90 to 95% of my hypo and Hashi patients have insulin resistance, and they don't know it because no one tested their fasting insulin to see if it was above a 6. And everyone's telling that their A1C of 5.7 is just fine, and that they're okay walking around with a fasting glucose of 105 because they're not flagged. But that high insulin is just going to create a ton of inflammation, and that's going to affect that conversion too. So there's so many factors. I always say converting T4 to T3 is like running a marathon, but with some hurdles in there. Like you have to run 26 miles and you got to jump over hurdles in the meantime. It's really hard to do. It's hard.
Yeah. I'm glad you brought up iodine, because that's one that I arm wrestle with myself quite a bit. And I think you're right on target with finding that Goldilocks dose, because I've seen autoimmunity triggered by high dose iodine,
right?
Or made worse. And yet there are some people who need it. So I'm kind of with you where everybody needs a trial, but the question is how much. Most supplements are going to give you 150 micrograms, which might be fine, but for other people, they need more. And I think some of it also depends on where you are in the world. Like Brownstein is in Michigan, which is in the goiter belt, right, where they don't have any iodine in the soil or very low amounts, versus other parts of the country.
Right. Exactly.
Do you agree with that?
I totally agree with that. Yeah. I mean, I like 150 for a minimum. And then sometimes we go higher and assess tolerance and do the salt loading on a daily basis, even for support of the adrenals, and do a couple times of Redmond's real salt in warm water and slug that down and chase it with 12 ounces of water. And that's a great way to kind of support the iodine effect when you're using it. Even if you're going up in your iodine dose, that's really good to implement. And then it helps support your adrenals too. I've seen too many people with low sodium and adrenal dysfunction at the same time. And I'm like, are you using salt? I mean, your sodium's 134. I mean, come on, we got to get that up. So, and that's going to play a role with fatigue too. We can we can always tie it back. We can always tie everything together. So if your sodium's low and you're not getting enough salt, that's going to make you fatigued. It's also going to hurt your adrenals. That's going to make you fatigued. If you're using iodine, you're not using salt. That's going to just make you feel like you're detoxing. So yeah.
Yeah, that's a good point. So let's get just a couple more questions left. This has been amazing. So let's talk about medications versus supplements or glandulars, Synthroid versus generic T4 versus Armour versus liothyronine or USP-T3. Like, what do you think is, and then a glandular, like what are your favorites? What do you think doesn't work at all? What are your thoughts on that?
Right. So, okay. I'll start with a question I got the other day on Facebook. Dr. Amie, what's your favorite thyroid medication? I go, the one that's going to make you optimized.
Amen.
She goes, which is? I'm like, the one that's going to make you optimized. I mean, I've heard other people talk about, well, if you're Hashimoto's, you have to be on like an NDT, natural desiccated thyroid, Armour, and all that. I don't find that's the case. I think it's different for each and every individual. And even in the NDT category, I've had patients that do well on Armour, not on Nature-Throid. Some that do well on Nature-Throid, not on Armour. They're like, oh, Armour is horrible. I'm like, not for everybody. So it really is about finding that happy medication type and then dose. So then, well, let's talk about the synthetics. So we have Levo, which is generic, Synthroid brand, and then Tirosint is kind of like the Mac Daddy of T4 because it's the most pure, the least amount of fillers. So when we look at Levo and Synthroid, some people will react to that and feel worse, but it's more because of the fillers that are in them. And now I have heard that I want to say it's Levo 50 microgram tablets do not have dyes, even though the tablets look white. Some of them still can have red and blue dye, and people will react to that if they're very sensitive. So I want to say that 50 microgram dye, but I don't have that confirmed. That was told to me by another doc, and I've never looked that up. But I mean, just in general, we go by, I like the brands. I like Tirosint because it's the most pure. If we're going synthetic, let's do Tirosint and liothyronine or Cytomel and find that happy dose. So the nice thing about the synthetics is that we can change the ratio. So if you're not really good at converting, if you have the DIO1, DIO2 genetic mutation, that means that you don't convert very well, then we might do just a little bit of T4 and raise your T3. Now we can do that with the NDTs as well. So if you're on an Armour, Nature-Throid, we can still add in T3 with your Armour. There's not a rule that says if you're on natural desiccated thyroid, you can't use a synthetic too. So we can use a little bit of T3 to change that ratio. And then we move into the glandulars. And you know what? My opinion on the glandulars is changing recently because I have seen people optimize on them. And I'm like, yeah, I mean, listen, it's working. If it's working, let's not fix it. Right. So I have seen people optimize on glandulars. And I want to tell you, I'm looking deeper into T2. I think that this is kind of a hidden gem. It's 3,5-diodo L-tyrosine or L-thyronine. Well, there's two of them. There's 3,5-diodo L-tyrosine and there's 3,5-diodo L-thyronine. And we kind of forget about T1 and T2 in the thyroid hormone. We always talk about T3, T4. But there is T1 and T2, and that has some promise in the supplement world of being like a T4 because it's not inactive. It's not like a T3. I'm sorry. It's not inactive like a T4. It's closer in relationship to T3, just a lesser strength. So for people that can't tolerate T3, can't get their doctor to change, we might be able to use T2 to really make some significant changes in their thyroid health. So that's kind of I'll get back to you on that. I'm diving more into the research.
That's very cool. And so by that rationale, also with the natural or the glandulars, where it's whole component or even the desiccated where it's ground up. I mean, oftentimes, because they're USP, they're not entirely non-synthetic, but but that you have more of a chance of getting the 1 and the 2 if you are in something that's
Yep.
more natural.
Yep, exactly. Yes, we do see T1 and T2 in the glandulars, in the NDTs. Yep.
Mm-hmm. And I've seen that sometimes people who are more sensitive do better on synthetics because they're reacting to things in nature anyway. Sometimes they're reacting to foods or they're reacting to inhalants, and then they react more to natural desiccated or whatever. Have you seen that as well?
A little bit. Yeah. I mean, that's where it comes down to that individual case of where you have somebody. I mean, usually by the time they get to me, they've either been stuck on T4 or they've tried a bunch of different glandulars or NDTs, and they just can't find their ratio. And you're right. It really does come down to, okay, you've been on levo. Let's move to tyrosine, more pure. Now let's add in some T3, because if you didn't do well on XYZ over here, let's just try something different. So yeah, I have seen that in some cases.
Excellent.
Mm-hmm.
So you are giving our listeners a free gift, and this is the Thyroid Lab Checklist. Can you tell us a little bit about that?
Yeah, so it is going to give you labs and symptoms. Number one, a huge list of symptoms that I'm going to tell you, they're eye-opening. Because when we talk about thyroid, we don't have time to list all the symptoms here. We talk about the big ones: the weight gain, the inability to lose weight, the hair loss, the fatigue, the brain fog, the depression, the constipation. Those are the biggies. But then we forget about the ones like increased sensitivity to allergies, hives, frozen shoulder, muscle pain, joint pain, migraines. I mean, it just goes down the list. So some of them, I mean, I've had people call me and be like, yeah, I've checked 35 of those boxes. So it's kind of eye-opening. And then I give you the labs to get, as well as the functional optimal values that we want. So I know you have your labs in front of you, and if you were lucky, you got all of them done. And then you say, well, my doctor told me I was normal. Okay, compare it with those lab and symptom checklists, compare with the optimal lab values, and make sure that they are in the optimal range, not just normal. We don't want it just normal.
Awesome. Yeah, thank you so much for sharing that with our listeners. And then where can people learn more about the wonderful work that you're doing?
Yeah, absolutely. Thank you for asking. So you can go to my website at dramieHornaman.com. You can listen to me on my podcast, the Thyroid Fixer podcast, which you were a guest on. So yeah, that was fun. That was so much fun. I love talking to you, Evan. We can do this anytime. So absolutely. If you're interested in a discovery call, you can go to my dramieHornaman.com page and click book a call, and we can chat and make sure that we are a right fit for each other and that I can help you. But you can do that as well if you're interested in my services.
Awesome. Dr. Amie, thanks so much for hanging out with me today.
My pleasure. Anytime. This was fun.
I hope you learned something on today's podcast. If you did, please share it with your friends and family and leave us a 5-star review on iTunes. It's really helpful for getting this information out to more fatigued people who desperately need it. Sharing all the experts I know and love and the powerful tips I have on fatigue is one of my absolute favorite things to do. If you'd like more information, please sign up for my newsletter, where I share all important facts and information about fatigue, from the foods and supplements to the programs and products that I use personally and recommend to others so that they can live their best lives. Just go to fixyourfatigue.com/newsletter to sign up, and I will send you this great information. Thanks for being part of my community. Just a reminder, this podcast is for educational purposes only and is not a substitute for professional care by a doctor or other qualified medical professional. It is provided with the understanding that it does not constitute medical or other professional advice or services. If you're looking for help with your fatigue, you can visit my website and work with us at fixyourfatigue.com. And remember, it's important that you have someone in your corner who is a credentialed healthcare professional to help you make changes. This is very important, especially when it comes to your health. Thanks for listening, and have an amazing day.